Assalamu alaikum. This is a presentation for medical students by Dr. Mumtaz Ahmed Umar, and today's topic is foreign bodies of air passages. A foreign body is usually inhaled by the children, and once it is aspirated into the air passage, it can lodge in the larynx, trachea or bronchi. Site of lodgement would depend upon the size, shape and nature of the foreign body. However, a large foreign body which is unable to pass through the glottis will lodge in the supraglottic area, and it can give rise to airway obstruction and in extreme cases instant death. However, smaller one will pass down through the larynx into the trachea or bronchi. Those foreign bodies which have sharp points like pins, needles, fish bones, etc. can stick anywhere in the larynx or tracheo-bronchial tree. Diagnosis is usually missed if the possibility of foreign body aspiration is not kept in mind. Etiology: it is usually seen in children, particularly under 2 to 3 years of age. The predisposing factors are those who have intolerance with swallowing, reflux. It can be accidental during playing, running about, laughing, crying or eating, or even in carelessness when dangerous objects are kept by adults inside the mouth, like a carpenter, he puts the nail inside the mouth to nail them in the wood, or if the dangerous objects are placed within the reach of infants. As small children, they have the tendency to put each and everything in their mouth, so peanuts, small tiny tags, safety pins, they should be kept away from the children. Then in unconscious patients, especially the comatose one or alcoholic intoxication or those under general anesthesia, the loose teeth or denture, they can be aspirated or fall down or may become a foreign body. Then those with pharyngeal and laryngeal paralysis. Incidence: the common age, as already mentioned, is 1 to 3 years. As I already said, that children have the habit of putting everything in the mouth, and different studies shows that male to female ratio is 2:1. Types of foreign bodies: there are two types of foreign bodies, the vegetables and the non-vegetables. Vegetables include the peanuts, nuts, seeds, peas, grains, etc., while non-vegetable can be anything, including the tiny pieces of elastic toys, safety pins, buttons, nails, fish bones, etc. Then the nature of the foreign bodies: it can be non-irritating or the irritating. So the non-irritating are the plastic, glass or metallic foreign bodies, which are relatively non-irritating. They may remain symptomless for a long time, as there is very less inflammatory reaction in the airway. While on the other hand, the vegetable foreign bodies, which are the irritating type like peanuts, beans, etc., they set up a diffuse violent reaction once they inhaled, leading to congestion and edema of the tracheo-bronchial tree. This condition is known as vegetable bronchitis. Second is, these vegetable foreign bodies, they also swell up with time, causing the airway obstruction and later on suppression in the lung. So these are the type of foreign body. It is a metallic foreign body in the bronchi, and this is a peanut. As we already know from our anatomy, that right main bronchus is in line with the trachea as its direct continuity, and secondly, it also has a wider diameter. So foreign body, once it aspirated, passed down through the larynx and trachea, they will usually lodge into the right main bronchus or the bronchioles, but it can also travel to the left side. Clinical features. Clinical features are divided into 3 stages. The stage of inhalation, which is the initial state at the time of entry into the tracheo-bronchial tree. There will be severe episodes of coughing, which should particularly be asked in during the history. Then choking may be there, gagging, dyspnea, wheeze or cyanosis. While with large foreign bodies, it can give rise to, as I already said, total impaction and instantaneous death. So the second stage is the latent stage, foreign body traveling to its resting place. No symptoms present, but signs they persist because the respiratory mucosa adapts to the presence of the foreign body. However, this period can be variable according to the type of foreign body. For vegetable foreign bodies, it is of very short duration, while for non-vegetable foreign bodies, it will take long time. The third stage is the stage of manifestation. Symptoms caused by the obstruction to the airway, inflammation, or trauma induced by the foreign body, and it will again depend upon the type of foreign body, size of foreign body, and the site of its resting place. Patient will have persistent cough. Again, the large foreign bodies may lead to impaction and obstruction and will cause death. Laryngeal foreign body. A large foreign body in the larynx may totally obstruct the airway, leading to sudden death unless resuscitative measures are taken urgently. However, a partially obstructing foreign body will cause discomfort or pain in the throat, hoarseness of voice, croupy cough, aphonia, dyspnea, wheezing, or hemoptysis. Tracheal foreign body. A sharp foreign body will only produce cough and hemoptysis. However, a loose foreign body like seed may move up and down the trachea between the carina and the undersurface of vocal cords, causing audible slap and palpatory thud. Asthmatoid wheeze may also be present, and it is best heard at patient's open mouth. Bronchial foreign body. Most foreign bodies enter the right bronchus because it is wider and more in line with the tracheal lumen. A foreign body may totally obstruct a lobar or segmental bronchus, causing atelectasis, or it may produce a check valve obstruction allowing only the ingress of air but no egress, meaning the air is only entering. We are inspiring but unable to expire the air out, leading to obstructive emphysema. There will be hyper-resonant percussion note, and very important sign is breath sounds. They will be decreased or absent on the site of infection of the foreign body. So this finding is very important in suspicion of a foreign body. So this picture, it will describe that check valve mechanism, types of bronchial obstruction by a foreign body. The A, it is showing partial obstruction. Air can pass in and out, causing only the wheeze. B, one-way obstruction. Air can go during inspiration but not out, causing emphysema of the lungs. The C, it will cause total obstruction. Air can neither go in nor out, causing obstructive atelectasis. And D is one-way obstruction, which will be the reverse of B. Air can only go out, causing atelectasis. Dark pink shows normal size of the lung, while lighter pink indicates the effect of obstruction. So these are the different types of foreign bodies. This is the laryngeal foreign body. If you visualize, this is the fish bone. These pictures, they are taken from the internet, but I myself have removed the similar fish bone lying on the vocal cords. This is little up, but the one I removed, it is just in this way on the vocal cords. Then this is the tracheal foreign body. The peanut, it's just at the level of the carina, and this is again the bronchial one, the peanut. Signs: there will be dyspnea, wheezing, fever. The chest movement, they may be poor, and there will be poor air entry in the chest. As I already mentioned, the breath sounds, they will be decreased or absent. So diagnosis, how will you diagnose? Diagnosis is basically on the basis of history, clinical examination, the clinical features, persistence of the symptoms, radiography, and bronchoscopy. So history, there will be sudden onset of coughing and bouts of coughing with wheezing or with or without choking. There will be triad of symptoms: cough, choking, and wheezing in about 91% of the patients. Choking followed by a paroxysmal cough and which later on subsides. The wheeze is unilateral and sudden in onset, and there will be usually no previous history of asthma. Auscultation will show diminished air entry into the lungs and on the site of the foreign body impaction. Hemoptysis can occur due to first if there is the sharp foreign body, or secondly once the foreign body is stayed there for long, so the granulation will develop and it will give rise to hemoptysis, and patient may have persistent or recurrent lobar pneumonia. The clinical features will show respiratory distress or cyanosis. Cry becomes hoarse or stridulous if the foreign body is large. There will be audible wheeze through the mouth, which is the hallmark of tracheal and the bronchial foreign body in children. On atelectasis, if atelectasis develop, there will be poor chest movements, vocal fremitus decreased or absent. There will be dull percussion note and prolonged expiratory phase accompanied by wheeze on auscultation, and audible click due to foreign body movement in the trachea up and down. So investigation, how will you investigate? So the first investigation is the X-ray chest, posterior anterior and the lateral view. If the foreign body is radio opaque, it will be visible, while the non-radio opaque foreign body, there will be medial shift on the ipsilateral side. There will be shifting, medial shift on the side of the foreign body. Ipsilateral means on which side the foreign body is present. Then it may show atelectasis and obstructive emphysema. If X-ray chest did not reveal the foreign body, then the facility of fluoroscopy is there, then one should undergo the fluoroscopy or video fluoroscopy. Blood CBC can be taken out to see any infection. Then very important, diagnostic bronchoscopy. Bronchoscopy is both, can be done flexible bronchoscopy or the rigid bronchoscopy, and in some cases CT scan has to be done. So this is a radio opaque foreign body in a child, a safety pin, if you can see, and this is the this is the laryngoscopic view. It is just in the supraglottis. These are the airway passage entry, glottis. This is epiglottis, so it is in the supraglottis. This again picture this from the flexible or the forceps, not the flexible, the forceps is taking out this safety pin, and in this picture the pin has been removed, but if you see there is slight injury in the mucosal surface of the supraglottis. So this is both the PA view and the lateral view showing the radio opaque foreign body in the bronchus. So this PA view of the chest X-ray shows obstructive emphysema due to the foreign body aspiration. Again, different types of foreign bodies. This is the nail in the right bronchi, and this is the broken piece of a tracheostomy tube, metallic tracheostomy tube. Its piece, it's broken down and it has gone into the airway in the bronchus. Treatment. The foreign bodies which are present in the upper airway, especially up in the trachea, Heimlich's maneuver can be tried. Heimlich's maneuver is basically in which the person, he goes behind the patient and holds his hand at the level of epigastrium and gives sudden thrust directed upwards and backwards direction, which squeezes the air from the lungs, and that will be sufficient enough to dislodge the foreign body. In cases of children, place the infant's stomach down across your forearm and give 5 thumbs on the infant's back with the heel of the hand. Then the other options are the bronchoscopy, which is the main laryngoscopy or bronchoscopy to remove the foreign body. Bronchoscopy can be both flexible or rigid. Vegetable foreign bodies needs urgent intervention because, as previously described, they can cause a violent reaction giving rise to vegetable bronchitis. Secondly, they also swell up and cause obstruction. whereas the urgency for non-vegetable foreign bodies are not that much severe. Other options can be, if it is causing the obstruction, the foreign body is causing obstruction, then tracheostomy has to be done to maintain the airway and remove the foreign body. Secondly, sometimes if the foreign body has stuck at carina or below that, then again tracheostomy can be done to remove from lower down. Patient should be started on broad spectrum antibiotics and steroids to combat the inflammation and infection. So these are the different types of instruments which can be used in the removal of the foreign body. This is the flexible bronchoscope. This is rigid bronchoscope, okay, of different sizes. These are the foreign bodies forceps, just the forceps to remove the things from the bronchioles or bronchi. And this is the direct laryngoscope. If the foreign body is stuck till the level of glottis, then direct laryngoscopy can be done to remove the foreign body. Rebronchoscopy. So who need a rebronchoscopy? Second bronchoscopy or rebronchoscopy is usually carried out to check if the foreign body has been completely removed or is there any suspicion of a second foreign body. Especially in cases of the vegetable foreign bodies like peanuts, it is cut down into different pieces, so we have to sometimes check whether all the pieces they have been removed or not. Secondly, if there is failure at the first attempt, okay, then it needs to be repeated within 1 to 2 days. Thirdly, if there is failure to find the foreign body, you do the bronchoscopy but no foreign body is visualized, but the symptoms and signs, they are persisting and radiography is not returning back to normal, so rebronchoscopy is carried out to check again whether any foreign body is missed initially, is present or not. So treatment, it continues. Tracheostomy, as I already mentioned, those large foreign bodies which causes obstruction, so to maintain the airway, tracheostomy have to carried out. Secondly, if you are doing bronchoscopy and you are passing through the glottis area, so it will lead to subglottic edema, and again it in turn give rise to airway obstruction, so tracheostomy may have to be carried out. Then thoracotomy. Thoracotomy is needed in those patients in which the bronchoscopy failed to remove the foreign body. So the patient has to be referred to a thoracic surgeon, in which case he will do a thoracotomy, open procedure to remove the foreign body. Postoperative care. Patient should be given regular steam, antibiotics and corticosteroids. They should be continued for a week to 10 days, and repeat the chest x-ray to see if the findings of the disease, they are coming back to normal or not. So what precautions you need to carry out during bronchoscopy? One, need to be prompt. Then damage to the teeth and air passages should be avoided, meaning you have to take down the bronchoscope slowly. Then keep the bronchoscope in line with the trachea to ensure adequate ventilation. You should be familiarized this thing, that once we pass the bronchoscope through the vocal cords, then there is no endotracheal tube. The anesthesia is given by the same bronchoscope. Okay, so we have to take care in this. Then vital signs should be measured side by side. If you are unable to see the tracheal rings, it means that you might have entered into the esophagus, so it can be very dangerous for the life of the patient. Complications of bronchoscopy. Number one, the bronchoscopy is failed. There is failed bronchoscopy, and you are doing 2-3 times, it gives rise to edema, so simply you cannot do it more. Then it can give rise to hypoxia, cardiac arrhythmias, bronchial rupture, pneumothorax, laryngospasm, hemorrhage, damage to the teeth, or accidental dislocation of cricoarytenoid joint. But what can be the complications of the foreign body? So the foreign body airway complications, immediate death due to asphyxia, pneumonia if the foreign body is not removed in 1-2 days, it can give rise to pneumonia. Many children, the pediatric patients, they are admitted in the peds ward with pneumonia, and then the pediatrician, once that pneumonia is not settled in 1-2 days, the conditions is not improving, they send the call to ENT doctor to rule out the foreign body. Then atelectasis, emphysema, lung abscess, brain abscess, cutaneous fistula, hypoxic cardiac arrest. So these are some complications of the foreign body of airway. So the take-home message, whenever there is suspicion of foreign body, the first and the foremost thing is the maintenance of airway. Airway can be maintained either by endotracheal intubation or by tracheostomy or cricothyroidotomy, but the first and most important thing is the airway maintenance. Once the airway is maintained, then according to the type of foreign body, it can be dealt accordingly. So thank you for your patience to listen this presentation.